The following podcast is part of a certified educational activity titled Individualizing Management Plans for Type 2 Diabetes Through Shared Decision Making, an office hours activity. Access the entire activity and complete the post-test at peerview.com/UTJ860. Downloadable slides and practice aids are also available.
Hello and welcome to Individualizing Management Plans for Type 2 Diabetes through Shared Decision Making and Office Hours Activity. My name is Lucia Novak, and I am the president of Diabesity LLC and the co-executive director of Capital Health and Metabolic Center of the Capital Diabetes and Endocrine Associates located in Maryland. So today's webcast was designed to fill gaps exposed by other recent continuing education activities on type 2 diabetes and weight management. And here's what we noticed about primary care clinicians' responses to some questions about initiating discussions for both type 2 and weight and using the shared decision-making process. While many of you answered questions correctly, we did see that some of you were unsure of your answers, maybe due to lack of confidence or just not enough information or knowledge. But we also identified some that were answered incorrectly. For instance, narrowly focused on clinical endpoints rather than the broader clinical context. For instance, you're looking at their hemoglobin A1C, and maybe you weren't realizing that a medication could also be really good to reduce the risk for a heart event or for heart failure, something along those lines. That you really weren't using shared decision making all that much, and you're more likely to rely on personal experience rather than the clinical evidence or the science backed evidence that we use when we're practicing. So therefore, our goals for today, we're going to initiate discussions about weight management and treatment intensification with people with type 2 diabetes who also have overweight or obesity. And hopefully, we will be able to equip you with strategies that will utilize shared decision making and help you to develop those individualized care plans. Starting the conversation. So what we're looking at here on this slide are the ADA, or the American Diabetes Association guidelines, that show that shared decision making is actually an important part, an essential part of developing that person-centered care plan that everyone speaks of when we're trying to help manage type 2 diabetes and actually any chronic disease that our patients might have. And as you can see, it goes around in a circle, and it starts with addressing the patient's key characteristics, thinking about specific factors that might impact your decision as to what treatment the patient may need, but then also using the information you gather from the patient to create a dialogue, a shared decision process where you can both then agree on a plan, implement that plan, provide ongoing support for the patient as they try to continue to implement, and then determining at a follow-up appointment somewhere down the line whether or not the plan that you both agreed on is working and do we need to make any tweaks. So for today's talk, we're going to be focusing on the blue box that identifies utilizing the shared decision making to create that management plan. And when we look at the details that are involved with shared decision making, one of those things is making sure our patients have access to diabetes education and support. So DSMES stands for Diabetes Self-Management Education and Support. And so making sure our patients have access to certified diabetes care and education specialists, certified classes for diabetes education, and registered dietitians who can provide medical nutrition therapy support for our patients. That's just the baseline of what they would need so that they can better participate in the shared decision making with you. And then, of course, we're going to involve not just the patient themselves, but if they bring someone with them to that appointment, a support person, we want to include them as well. And I encourage my patients that if they live with someone or have someone that they rely on to assist them with their activities of daily living or medication taking, that they include that person, invite them to join us, because you could always use an extra set of eyes and ears at an appointment. And then, of course, we're going to explore what the patient understands, what their preferences are, and how we communicate to the patient. Also, want to make sure that we don't call them a diabetic or that they are obese. We want to use patient-centered or patient-focused language. So it would be you have diabetes or you also have the disease of obesity. It kind of gives the person their autonomy and it doesn't assign them a diagnosis as to who they are. And that really does matter. And then talking at the last bullet about motivational interviewing. And I think when people hear motivational interviewing, the eyes just kind of roll back, because we understand that while it is important to do motivational interviewing to involve the patient in the decision process, it's probably a skill that many of us don't use very often. We may not be comfortable with, and we're probably thinking, oh my goodness, I don't have the time. So hopefully I can share with you how I practice, and maybe it can help make it seem less intimidating for you and the patients as well. We know that shared decision making works. So it would not be included as a recommendation in the American Diabetes Association guidelines if there wasn't some research behind it to show that it actually does work. And so this is just one of many studies that looked at shared decision making in a population that have type 2 diabetes. And what we found is that about 38% of the patients that were polled in this particular study perceived that they had some degree of shared decision making with their clinicians. And less shared decision making was associated with the person being older, being male gender, or uninsured. And so, again, we want to try to bring these numbers up because we have seen that when shared decision making is at a higher level or a higher perceived level, there is an increased satisfaction with care. And when patients are satisfied with their care and they feel that they are being included and adequately addressed, them and their needs, they tend to be more open with us. And as a result, we get further with them when we're trying to accomplish certain goals. Shared decision making was not necessarily associated with medication adherence, but it could be just the way that that was measured. I have seen other studies where we have seen a drop in hemoglobin A1C, as well as improvement in depression scores, as well as diabetes distress with patients who feel that they have an open dialogue with their healthcare provider and that they feel that their questions and their concerns were included in the development of the plan. So while we know it's important, it's obviously included in the guidelines. We have data that supports that it is very effective. What's probably missing for most of us clinicians is that there really isn't much guidance on how to involve patients in the shared decision-making process. And so the Mayo Clinic probably has done most of the research that is involved with shared decision making. And they have come up with three approaches. One is to share that information. So, again, and that's a two-way street, the patient sharing the information about themselves once they understand what we are working toward. You know, does what we are presenting to them work in their life? And we are also sharing the information about what the disease process is, what we are trying to help them accomplish, and what therapies are going to be needed to accomplish those goals. The second approach would be patient choice. And so I I proceed with caution here because yes, their patients always have a choice. And no choice is also an option if they choose not to do anything. What our responsibility is to make sure that they are making an informed choice. So if you think of shared decision making almost like informed consent, then you will have a better understanding of what the shared decision making process is. They need to know what the results are of their actions as well as inaction, and what are the realistic options that are available to them. And then they can make a choice. Of course, the third approach is having a conversation. And to me, that would include both sharing the information as well as understanding what the patient's choices are and why their choices may be that way. So let's first introduce a case. And this is a woman that is 57 years old, and her name is Anna. She is newly diagnosed with type 2 diabetes, and you saw her for the first time about a month ago. At her diagnosis, her A1C was 8.9%. And at her initial visit, you referred her to diabetes education as well as a registered dietitian to help her with her lifestyle changes that were needed to better manage her diabetes as well as improve her overall health. She did indeed attend the classes and has met individually with a registered dietitian for her medical nutrition therapy. And she has found that using the plate method has been a simple as well as effective way to help her with making appropriate portions and also working on decreasing her intake of ultra processed foods. She is now walking twice weekly for at least 20 minutes, and she wasn't doing that at that initial visit. So now we need to get Anna talking about how she feels that she is doing and what we think needs to be done better. And I will tell you that a patient's ability to want to participate in the shared decision making process is really going to depend not on just how much knowledge they have, but how much perceived power or capacity that they can bring to the appointment. Is their opinion taken seriously? Do they value their own opinion, or are they deferring primarily to what you're telling them to do? So, our goal is to help our patients feel empowered in that encounter so that they can be involved. But there are things that get in the way. And some of the things come from the healthcare provider side as well as from the patient side. So, what I have found, especially in diseases where lifestyle modifications are a significant part of the therapeutic plan, whether that be type 2 diabetes or overweight or obesity management, we have some inherent biases. We're human. We're going to bring those biases to every appointment we have with our patients. It's important that we understand what our biases are because they will translate. And oftentimes, if we're not aware of them, they will not be in relation to what words we are saying, because our body language and other things will convey a different message to the patient. So we want to make sure that we understand what our limitations are and that we address them. You can't get rid of your biases, but you can address your biases, and you can tone the language and change some things about yourself that will actually bring the patient into that empowerment phase and participate in the shared decision making. And as I mentioned, the patient also brings some baggage with them. And oftentimes, what I have come to appreciate, it's not just whether or not they have an income that can afford the medications or afford the appointments, although that is rather significant. But our patients aren't just people with diabetes. They are patients with a full life. And there are so many other things that can get in the way. And if you look at just the cost of receiving care for diabetes, 20% of it is spent on just getting access to us. That doesn't talk about the medications and so on. But they have families and they work and they may be in school, and there's all these competing priorities that sometimes overwhelm the patient and will limit their ability to successfully implement a plan we may have discussed or from participating in the appointment in general. They may be um, ashamed, they may be embarrassed, or they just might feel like they just don't know how to even begin to talk to us about what's going on in their life. So there are some ways to kind of bring that information to them. And so this slide is showing you from the bottom up. So we would start by engaging the patient. And that again is not just by the words we say, it's also by our nonverbal communication. And that would include making sure that the seating in your office is accommodating for people who do have overweight or obesity, that they feel comfortable coming into your office and sitting down. And then using your body language where you're making eye contact and you're leaning forward and listening. And the other piece of that is also if you ask them a question, and hopefully an open-ended one that they are going to need to think and give you the information that you're looking for, that you pause long enough, because sometimes this might be the first time someone has actually asked them about what's going on in their life in a clinical appointment office. And so don't be in a rush to fill in the dead space of no talking. Allow the patient to process your question and then give them time to answer. I like to use the acronym WAIT, or W for why, A for am, I for I, and T for talking. Why am I talking? Let the patient fill in the void with the question that you have posed them. The next step would then be focusing. I like to ask my patients when they come into the office with me, was there anything specific that they really needed to address today before they leave my office? I may have a whole different plan in mind, but I have come to really appreciate that when patients feel that whatever need they had got addressed, even if I did not get to some of the things I felt were important, they leave my office feeling very satisfied, very heard, very listened to, and they're more likely to come back for their next follow-up appointment and will continue to be engaged. So again, trying to develop an agenda with the patient. They may have some things they want to address, and you can say, okay, and I have some things that I also want to make sure we cover today. So let's get to it. And then, of course, comes evoking, making sure that you are helping the patient to bring forth whatever information you need. And that could be by finding something positive that is going on in their life. So, they haven't taken their medication, they haven't done walking, their diet hasn't been the best because it's the holiday. And I say to them, but you're here today. And that is huge, because they could have chosen not to keep the appointment, as often happens when patients feel that they have not kept their end of the bargain. So I'm always looking for something positive to kind of reassure them that I am on their side with them. And I recognize the difficulty of trying to manage more than one chronic disease. Diabetes seldom comes by itself. There's usually the buy one, get three free, hypertension, dyslipidemia, weight, and then the complications of the weight. They may have bad knees, a bad back, they have sleep apnea, so on and so forth. And again, this is just a piece of who they are. There is so much more to their lives. So trying to get them to talk to us is going to be really important. And then the last thing is, once we've gotten them talking and we've identified some things that are important to them, we have relayed the things that are important to us as far as their management, then we can come together and determine a plan that we both feel comfortable with and that the patient feels able to put into place. So the 4 skills are going to be open-ended questions, which I mentioned, those affirmations, again, trying to find something positive about what the patient has succeeded with since their last appointment, even if it is just coming in today when they felt that everything was just lost since the last appointment. And then, of course, the reflective listening, validating what they have to say. Oh my goodness, I can only imagine how hard this is for you. You have so many medications that you have to pay for, and you're on a limited income. So let's see if we can't figure out how to better address this. Again, you're listening to them. I see that this upsets you, and you know what? I understand why you're upset. Those are huge, validating the patient, what they're feeling. And then summarizing what they have said. This is what I'm understanding is the issue. These are your concerns. Please let me know if I've misheard you. And then also inviting them to summarize what they have understood from you to have said, so that you can clarify if there was anything. When we talk about obesity management in specific, because it is such a high stigma associated chronic disease, we are actually encouraged, and Medicare wants to see this documented in the chart, that you are using the 5 A's when talking about sensitive subjects, and that includes when you're discussing somebody's weight. And so we would be asking for permission. That's something that seems strange. We don't ask permission to discuss their blood pressure or their cholesterol. They're in our office. We assume they are here for our help. But when it comes to a stigmatizing type of disorder, we do want to ask their permission, because maybe they don't want to talk about it. And what we need to do is at least open the door. We're asking their permission, letting them know that they have the ability to participate in this conversation or not. If they're wanting to talk about it that day, then we let them have at it, correct? Like, we go ahead, tell me what's going on and what you've done that worked and what hasn't worked and what can we try to do better. But if they say, you know what, today's not the day, I just am not ready to talk about my weight, and you can then say, okay, I just want you to know when you're ready, I'm here and we can talk about some things that we can do together, and leave it at that. And I have found that patients will come back and be ready to have those conversations. We are also overwhelmed as healthcare clinicians on different goals that we need to help achieve with our patients. So, what exactly are we looking at? Are we looking at improving their diabetes? Are we looking at reducing their weight? Is it their blood pressure? Is it their cholesterol? So, a lot of competing, again, priorities, but oftentimes they're so often interwoven that if we can address one, we typically do a really good job with addressing the others. And this slide is showing you an example of therapy that we can use that can do that. So certain medications, and you're seeing here a pattern of the GLP-1s and the SGLT2 inhibitors that will help reduce that atherosclerotic cardiovascular disease risk, help improve glucose as well, and not necessarily increase weight for our patients, hopefully helping them to lose weight. So, it's important that we give this information to the patient, that there's a potential that using one or perhaps maybe two drugs, we'd be able to hit many things. What I like about this particular slide is it helps set the stage for when we're talking about weight loss with our patients. People with type 2 diabetes do not lose as much weight as those without diabetes on the same exact treatments that we use for obesity management. And what this slide is showing you is the average weight loss that you can expect when taking these medications. So patients, they seem to think that if I start this drug, I'm going to lose 50 pounds. And that's not necessarily going to be true. Everyone responds to these differently, but this gives us an idea of about how much weight we can at least expect a patient to lose, and then what else we might need to do to help the patients accomplish those goals. And it could be combining agents, it could be referring them for a bariatric procedure, all of those things. So when I have a patient that is not comfortable with intensifying treatment or wanting to use a medication, especially when it comes to type 2 diabetes, I will bring up the ominous octet, and the name is going to be changing to Noxious 9. And I think Dr. Stan Schwartz actually has an egregious 11. We keep finding pathological reasons for hyperglycemia. And the reason I bring this slide up with my patients is to show them there is not a mouth and there is not a foot on this particular slide. And it's not that the lifestyle as well as what they're eating and what they're drinking are not important. I'm trying to focus this less on the shame and blame that often is tied to nutrition and physical activity, and more on the disease process. And just based on this slide alone, there are 8 things outside of how much exercise a person does and what a person eats that contribute to that hyperglycemia. And that is going to set the stage to help me to help them understand why a medication is needed. And patients really do want to know what to expect from a medication, not only the side effects, but I often get, am I going to need to take this for the rest of my life? And I tell my patients, my goal is that you live a very full life with very few complications and on the lowest dose of medication that you would need. So it's going to depend on many things, on what type of medicine and how long they would need it. And again, we as clinicians need to be comfortable with the medications that are available and how to prescribe them and what side effects to counsel the patient on to expect. What I love about this slide is that just as if a patient were on blood pressure medicine and they decided, oh, your blood pressure is at goal, let's stop the blood pressure medication. You don't seem to need it anymore. What we would see is their blood pressure would rise and their hypertension would no longer be adequately addressed. And that is true for just about any disease, to include type 2 diabetes and obesity. So when patients ask, how long do I need to be taking something? I tell them, as long as you have the disorder or the disease, I do not have a cure. We need to do our best with maintaining stability so that you have good health with minimal complications. So now that we've covered the groundwork, let's revisit Anna, our patient that we discussed and I introduced you to at the beginning. And this activity does include some helpful practice aids. And again, you're going to be able to download them from the PeerView website. But let me show you how I would use them to navigate patient-centered discussions to reflect Anna's needs and goals. So today, Anna is in for her first month follow-up with me since her initial diagnosis of type 2 diabetes. She's already been to see the dietitian and she's attended classes. Today, she's expressing concern that while her blood sugars have gotten better, they remain above the targets discussed of less than 120 and less than 180 after she eats. She said she's running anywhere from 120 to 130 before she eats, but it's really her after meals that are concerning her. They're going up as high as 210. And she's also upset that instead of losing weight, she is gaining weight. And she reinforces that she was really hoping to avoid medications. This was something that she mentioned in our initial appointment a month ago, which is why I said, okay, let's get you in to see a dietitian. Let's get you into some classes, and why I scheduled her appointment with me for a month later so that I could quickly intervene and make sure that she was doing okay. So these are her concerns, and now we need to address them. So this slide here is facilitating discussions with your patients about intensifying therapy for type 2 diabetes and weight. So I didn't mention Anna's weight, but most 42% of the adults in the United States have a BMI that's high enough to put them in the obesity category. So it would not be surprising that there was some issue with weight. So while I may not have mentioned it, let's say that she does have a BMI of about 32. So it's not just enough to address her blood sugars, but we also have to think of that comorbidity. On top of that, she's gained more weight. So I'm going to reassure her that the weight gain that she experienced is a natural phenomenon that we see when blood sugars actually get better. And so our goal is that with ongoing exercise that she has implemented and the significant changes to her diet, that will eventually even itself out as her glucoses improve, and hopefully she will start to lose some weight. But I am concerned, as is she, about her post-meal elevations. So we'll talk a little bit more about what it is that she's eating, see if there's anything else that we can tweak. But this is where I am going to talk about type 2 diabetes as a disease process, not just focusing on the lifestyle management And so, again, this is where I will bring up that ominous octet with her. And I will show her that outside of what she eats and the exercise she does or does not do, there are 8 pathological functions inside her body that are contributing to the hyperglycemia. And I can also going to show her some of the medications that we use for managing diabetes. And yes, I will include insulin in this discussion because I never want insulin to be made to feel as a threat or as a punishment. But we'll talk about what the options are, what the benefits are, and go on from there. And so hopefully by the end of that appointment, she's willing to do something in addition to taking a medication to help reduce her risk, to help get that A1C down, and help her live her best life. All right. So, in conclusion, and to summarize, that when you're starting that shared decision making process with your patient, please remember that there are some important things to consider. Not just the patient's point of view, but if they do have a support person in their life that does help them with activities of daily living or management of their disease process, whether it be helping them with meds, have them bring that person in because they can provide some additional insight. And keep in mind that we have tools available, not just for the patient, but also for us as clinicians to kind of help guide us through this process and to really strengthen our skills. And then making sure that we implement strategies that we feel comfortable with to get our patients participating in those shared decision making and understanding that those preferences and those limitations that the patient may have to be part of our consideration when we are developing that plan. We know there are many benefits to shared decision making, and probably the most important of all is the increased trust that the patient will have in us as their healthcare clinician, but also the trust that we now have in them that they are going to be forthright and, honest with what's going on in their life, regardless of what's going on in their life and how it may actually make them feel, that we are on their side throughout the process. So this concludes the formal part of my presentation for today. If you missed the first 2 office hours activities on prioritizing weight management and overcoming therapeutic inertia, please search for office hours on the PeerView website to locate these activities.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/UTJ860.